Hello, good morning. I'm Elisa Kern de Castro. It's a pleasure to be here with you. I want to thank Professor Christopher Wicklittis and Professor Maria McCartney for the invitation to talk about PTSD in childhood cancer survivors. The title of my presentation is Post-Traumatic Stress Symptoms in Childhood Cancer Survivors and Caregivers. Are they related? I have no conflict of interest. Well, this is an overview of my presentation. First, I will talk about the relationship between Ptss in childhood cancer survivors and caregivers. Second, different stressors that children and families need to cope with when they live in low and middle income countries. Third, I will present some results about our research with childhood cancer survivors and caregivers in Brazil. And fourth, I will talk about limitations, conclusions, and clinical implications. To understand the post-traumatic stress symptoms in childhood cancer survivors and caregivers, we need to recognize that acute stress is a normative reaction to the disease and hospitalization during childhood for children and families. So, families will experience symptoms of Ptss at some point after treatment. We experience avoidance, arousal, negative mood and emotion. As a person in development, the child's regulatory functions, including their stress response symptoms, are strictly related to their relationship with primary caregivers. So if the mother or father is very stressed, the child will feel the caregiver stress and will react to the caregiver stress. Here, there are the phases of the integrative model of pediatric medical traumatic stress. We are focusing on phase 3, long-term PMTS, when cancer treatment is concluded and long-term traumatic responses appears. In childhood cancer survivors, the PTSD rates vary a lot. For survivors, PTSD rates ranging from 9 to 34%, and for caregivers, PTSD rates more from 4 to 75%. The rates vary according to the measure used in the research, as well as the different characteristics of the sample. We need to understand that childhood cancer is a complex traumatic stressor, and it's difficult to differentiate which is the experience most traumatic in childhood cancer. If it is the diagnosis, the cancer diagnosis, the treatment, the hospitalization, the pain, the suffering of their parents, their change in their body, and others. All the experiences are very, very traumatic. A recent meta-analysis identified some predictors of PTSD in childhood cancer survivors, just in survivors, not caregivers. The authors found that maladaptive coping strategies, especially focusing on emotion, the low perceived social parent support, the late effects of treatment, the tumor type, especially if the child has brain tumors, the poorly functioning families, that is, they have a lack of affective responsiveness and involvement, and mother's PTSD are predictors of children PTSD. Now, regarding the relationship between PTSS in children and caregivers, another meta-analysis with non-CC survivors, the sample included different traumatic events for children. Authors found that parent-child PTSS has significant effect size, and the moderators of this relationship were maternal PTSS, the use of the interview to collect data about PTSS, and longitudinal studies design. Regarding specifically the relationship between PTSS and childhood cancer survivors and caregivers, another study with different types of childhood chronic disease, including CC survivors, assessed the PTSS 2 times, in the first weeks after diagnosis and 1 year later. They found that initially high levels of PTSS in mothers and fathers were longitudinally related to poor recovery of PTSS in the child. PTSS of mothers and fathers were correlated between time 1 and time 2, but they didn't find a correlation between PTSS of caregivers and children. These findings mean that mothers and fathers react similarly to the stressors, but child response is independent of the parent's response. All of these studies that I mentioned were carried out in middle and high income countries, mainly Europe and United States, and others too, but many in Europe and United States. None of these studies included samples from low and middle income countries like Latin America countries. So we need to understand that when we talk about children and families from developing countries, they may have other potential barriers regarding the childhood cancer diagnosis and treatment that could be more stressful and more traumatic. So maybe they need to cope with more stressful events, and we don't know how they cope with and what is the consequence of this experience for their lives and their PTSS. In low and middle income countries, many times caregivers have a low educational level and more difficulty to recognize symptoms as a possibility of cancer. Difficulties to access healthcare, because healthcare is in many times insufficient, and caregivers don't have enough health literacy to cope with and to search healthcare. Social support could be less effective to help them to cope, and many times the distance from home to hospital is very far. Imagine if the family lives in the country of Brazil, very far from the cancer center. It's common they live 500 or farther kilometers from the hospital. They never traveled more than a few kilometers from home. And suddenly they have a very sick child, and they must go to an unknown place without resource, economic and psychological resource, because near of their home, they do not have infrastructure and a resource for their child. In a big city, families don't have social support, economic resource, the governmental help are uncertain, many times are less than they need to live, and they don't have a job. And also health professionals, especially doctors and nurses that work far from cancer centers, they don't have a specific training in childhood cancer diagnosis. So it's a very difficult situation for families, and it's common that during this process to seek help for the child, the diagnosis is late and the prognosis is poor. Especially in Brazil, Brazilian healthcare is very, very heterogeneous. I usually say that in Brazil, we have the best and worst, depending on where you live and where you come from. Although there is a universal healthcare system, access to healthcare and the quality of healthcare are very heterogeneous among the different states and cities. So the follow-up care is limited. Most centers don't have follow-up care for children, and if the survivors need some specific care, like rehabilitation, many times it depends on the family resources, or they enter in a waiting queue for the treatment. So I will talk about some findings regarding a study that my colleagues and I did in Brazil with childhood cancer survivors and caregivers. In this presentation, my focus is on the relationship between Ptss in childhood cancer survivors and caregivers. Our data is from a Paediatric Oncology unit at a public hospital in southern Brazil, in Porto Alegre City. Families received the multidisciplinary care by a non-governmental care called Instituto do Câncer Infantil. Their main goal is to help families have a place to stay while the child is in the hospital, and also provide food and essential needs for families. This is where Brazil is located, and Porto Alegre is located in the southeast state in Brazil. And here you can see in detail the Rio Grande do Sul map and a picture of Instituto do Câncer Infantil building. In our study, we included 46 childhood cancer survivors' caregivers' diets. Here you can see some detail about our sample. I will not read all the information because of the time, but I want to give special attention to the information about childhood cancer survivors' age. Average age is almost 17 years old, and their mean time of follow-up, almost 6 years. Regarding Ptsd percentage in our sample, you can see in this table some interesting information. If you remember in the other slide, when I talked about Ptsd rates, we can quickly realize that our findings of Ptsd are very, very high. For example, when we see the caregivers re-experience rates, 76%, it's extremely high. 50%, half of the caregivers presented avoidance symptoms. In general, caregivers presented more symptomatology than survivors, re-experience, avoidance, and arousal, but survivors presented more rates of general PTSD. And here we have a picture that I picked from a paper that my colleagues and I published last year regarding the relationship between general Ptss in childhood cancer survivors and caregivers quality of life. We found that caregivers' post-traumatic stress symptoms mediated the association between survivors and caregivers' quality of life. That is, in the middle of the relationship between survivors' Ptss and caregivers' quality of life, we have the caregivers' Ptss mediating this association. In the next slide, I show you unpublished data from network analysis to understand the path of the association between the same variables, but we included the clusters of post-traumatic stress symptoms. Then you can see these associations. In blue, we have the survivors' Ptss. In pink, we have the caregivers' Ptss, and in green, we have the dimensions of quality of life. We measured quality of life with RUCOL, a measure recommended by the World Health Organization. We can see the connections between the survivors' Ptss and parents' quality of life raising to parents' Ptss. If you see the image in more detail, the connections between survivors' Ptss and caregivers' Ptss are located between survivor cluster B, re-experience, and parents cluster D, negative cognitions and mood, and survivors cluster D and parents cluster B. This is a weak but a positive connection between these clusters. Regarding caregivers, Ptss, and quality of life, the strongest connection is between caregivers cluster D, negative cognitions and mood, and psychological dimension of quality of life, and then the physical dimension of quality of life. What may I think and discuss about these findings? Regarding diets, they have different experiences that influence each other. In this experience, I want to call attention to caregivers' experience and avoidance too, but especially experience symptoms that was extremely high in our sample. We need developmental comprehensions of Ptss in childhood. The theories about medical trauma in childhood need to be increased, and that take into account the cognitive and emotional development of the child to understand the later psychological consequences for survivors. There is scientific evidence about how children develop the concept of health and illness, but we need more research about how this development are related to medical trauma Ptss and this relationship with caregiver symptoms. The medical staff needs to be trained to identify post-traumatic stress symptoms in survivors and family. And medical staff must know about the symptoms and know how to identify them in consultations and refer families to mental health care. Multiple stressors in low and middle income families should be assessed to better understand their effects on mental health. It's necessary more research about the other stressors that these families need to cope with. And these studies, including mine, have a lot of limitations. A small and mixed sample, cross-sectional studies, a few studies with diets and others. Regarding clinical implications, some questions remain. What is potentially traumatizing about cancer for children and their families, especially in families from low and middle income countries? What are the targets for intervention for traumatic stress in children and families? The main goals of the intervention with survivor and families are to reduce post-traumatic stress symptoms, to promote positive adaptation, and better understand the social context of the family. We need to help families to recognize and to reduce the survivors' exposure to potentially traumatic events. Help families to improve the childhood cancer survivors' routine to compensate for their experience on the unpredictable treatment course, and considering childhood cancer survival with long-term side effects and its potential stressors, for their mental health, and attend caregiver symptomatology to help them to cope with cancer survivors' symptomatology. The future directions, I have two suggestions right now. First, more research about post-traumatic stress symptoms and attachment to understand better their relationship, and Ptss in children and caregivers, caregivers and children cognitive development, to understand better about health and illness, memories about the disease and treatment, and all this relationship. These are my reference that I use in my presentation. And thank you very much. Here is my email if you want to contact me in the future. Thank you.